Hello, everybody. I'm Dr. Sarita Rao, Senior Intervention Cardiologist from Apollo Hospital, Indore. And today we're going to look at the day 2 updates from the ACC Chicago. So today's 6 very interesting trials were presented there. The first is a double-blind randomized controlled trial of an autologous cell therapy in patients with heart failure, reduced EF, the principal results from the CARDIAM heart failure trial. The second was the FAIR heart failure 2 trial results. The third was the Mighty Heart randomized clinical trial. The fourth was the 5-year outcomes after transcatheter or surgical aortic valve replacement in low-risk patients with aortic stenosis. The fifth was a global effect of cardiovascular risk factors on lifetime estimates. And the last was the Smart Choice 3 trial. Now, when we're talking about the CARDIAM heart failure trial, this is because heart failure, basically following an MI, is a common disabling and a deadly condition, and they decided to do a direct injection of autologous bone marrow mononuclear cells into the myocardium, and they thought that it may result in improved functional recovery, it could relieve symptoms and improve other cardiovascular outcomes. So this was a randomized, double-blind, sham-controlled, pivotal trial designed to investigate the safety and efficacy of autologous bone marrow mononuclear cell treatment for patients with medically refractory and symptomatic ischemic cardiomyopathy. What was the primary endpoint? It was the change in the 6-minute walk distance adjusted for major adverse cardiovascular events at 12 months following treatment. Particularly, what was novel in this trial was that they included a cell potency assay to screen subjects who have bone marrow cell characteristics that suggest a favorable response to treatment, a point-of-care treatment method, and a high target dose of 200 million cells, and an efficient transcatheter intramyocardial delivery method that was associated with high cell retention. What was the results? They found that the patients who received a single endomyocardial dose of autologous CARDIAM cell therapy while on maximal medical therapy had a 37% relative risk reduction in all-cause heart death equivalents and a 9% relative risk reduction in non-fatal incidence of MACE during a mean 20-month of follow-up. Also, they had an approximately 5% lower rate of heart death equivalents at up to 2 years compared to control patients treated with heart failure medication alone. That is about 8.3 versus a 13.2 respectively. The CARDIAM cell therapy arm was also associated with trends towards reduced ventricular tachyarrhythmias, enhanced heart function as measured by the left ventricular ejection fraction, and improved NT-proBNP. So these patients also experienced an 86.2% relative risk reduction in heart death equivalents and a 23.9% relative risk reduction in MACE. So typically, it was found to be safe. However, the study did not meet its primary efficacy outcome when assessed during the 6-minute walk test as the third Finkelstein-Schoenfeld tire. And despite this additional analysis showed favorable outcomes when quality of life was used as the third FS tire, with a trend towards a benefit in the overall study population and a statistically significant improvement in patients with an elevated NT-proBNP or a BNP. So the 2-year results suggest that administration of these cells would provide clinical benefits for patients with ischemic heart failure with reduced ejection fraction and elevated NT-proBNP or NP who are on stable guideline-directed medical therapy. Let's look at the second interesting trial that was the FAIR heart failure 2 design. And this was designed because there's a lot of uncertainty which remains about the efficacy of IV iron in patients with heart failure and iron deficiency. So the objective was to assess the efficacy and safety of ferric carboxymaltose in patients with heart failure and iron deficiency. It was multicenter. It was a randomized clinical trial which enrolled 1,105 patients with heart failure. Now, these were patients who typically had an ejection fraction of less than 45%. And iron deficiency was characterized as a ferritin level of less than 100, or if the transferrin saturation was less than 20%, a ferritin level between 100 and 299. This was done at 70 clinical sites in 6 European countries from March 2017 to November 2023. The median follow-up was 16.6 months. So what did they do? They administered ferric carboxymaltose, initially given at an IV dose of 2,000 milligrams that was followed by 500 mg every 4 months versus a saline placebo. Now, the primary endpoints which they looked at were time to CV death or first heart failure hospitalization, total heart failure hospitalizations, and the time to CV death or first heart failure hospitalization in patients with a transferrin saturation of less than 20%. Of the 1,105 participants, the mean age was 70 years, 33% of them were women. And cardiovascular death or first heart failure hospitalization, which was the first primary outcome, occurred in 141 in the ferric carboxymaltose group versus 166 in the placebo group. The second primary outcome occurred 264 times in the ferric carboxymaltose group versus 320 times in the placebo group. And the third primary outcome, again, occurred in 103 patients in the ferric carboxymaltose group versus 128 patients in the placebo group. However, when they looked at it statistically in patients with heart failure and iron deficiency, ferric carboxymaltose did not significantly reduce the time to first heart failure hospitalization or CV death in the overall cohort or in patients with a transferrin saturation less than 20% or reduce the total number of heart failure hospitalizations versus placebo. The third interesting study was the comparative effectiveness of mobile integrated health versus a transition of care coordinator in patients with heart failure. This was the Mighty Heart randomized clinical trial. So, mobile integrated health leverages existing emergency medical services infrastructure to provide care beyond the 911 system using community paramedics. And prior studies of telehealth alone have not demonstrated significant reductions in preventable healthcare utilization among patients with heart failure. So they're using mobile integrated health and telehealth to support transition of care among heart failure patients. The Mighty Heart was a comparative effectiveness trial of MIH compared to traditional transition of care post-discharge program. This was a pragmatic randomized clinical trial, and admitted patients with heart failure were enrolled prior to discharge across the two health systems and randomized either to MIH or transition of care programs. The primary outcomes included hospital readmissions based on Medicare claims and a change in quality of life using the Kansas City Cardiomyopathy Questionnaire at 30 days. Secondary outcomes include preventable emergency department visits and unplanned hospital admission up to 90 days post-hospital discharge. The results, however, showed no significant difference between the two arms in hospital readmission at 30 days. However, the results also revealed differences by sex. Women were 30% less likely to be readmitted on an all-cause hospitalization and 36% less likely to have a heart failure-related readmission as compared to men in the mobile integrated health arm. The results also suggested that patients younger than 70 years old may be more likely to benefit from mobile integrated health. The observational data suggested that patients who are sicker, those who are more affected by social determinants of health, such as financial stressors, lack of caregiving support, likely benefit more from this intervention. In the MIH arm, younger patients exhibited a 4.5-point health status compared to younger patients in the TOCC arm. To conclude, there were actually no significant differences between treatment arms in 30-day and all-cause readmissions or overall health status. However, significant interaction effects suggested that the benefits of MIH may be greater for younger patients and women. These findings actually highlighted the importance of understanding differential treatment responses based on age and sex, which can actually help refine and optimize the implementation of MIH to better target patients who are more likely to benefit. The next trial, which was presented, looked at the 5-year outcomes after transcatheter or surgical aortic valve replacement in low-risk patients with aortic stenosis. Now, the background of this was that the Evolute low-risk trial had actually demonstrated that transcatheter aortic valve replacement was non-inferior to surgery for the primary endpoint of all-cause mortality or disabling stroke at 2 years. Outcomes at 5 years have not been reported. But in this study, they sought to evaluate a 5-year clinical and hemodynamic outcomes with TAVR versus surgery in patients from the Evolute low-risk trial. So patients were randomly assigned in low-risk patients with severe AS to either TAVR or surgery. The primary endpoint was a composite of all-cause mortality or disabling stroke. The secondary endpoints included clinical, echocardiographic, and quality of life outcomes through 5 years. There were a total of 1,414 patients who underwent an attempted implant. The mean age was 74 years. Women accounted for 35% of the patients. At 5 years, the Kaplan-Meier estimate for primary endpoint of all-cause mortality or disabling stroke was 15.5% for the TAVR group and 16.4% for the surgery group. Again, non-cardiovascular mortality in the TAVR group was 6.8% and 6.2% in the surgery group. The all-cause mortality rate at 5 years for patients undergoing TAVR was 14.7%, and for surgery was 15.2%. Over 5 years, the valve reintervention rate was 3.3% for TAVR and 2.5% for surgery. So at 5 years, it was seen that patients with severe aortic stenosis who were treated with either TAVR or surgery had comparable rates of all-cause mortality or disabling stroke. Valve durability and performance were found to be excellent in both arms. This midterm evaluation reinforced the position of TAVR as non-inferior to surgery in patients with severe aortic stenosis at low surgical risk. The next trial looked at the global effect of cardiovascular risk factors on lifetime estimates. Now we know that 5 risk factors actually account for approximately 50% of the global burden of cardiovascular disease. Now, how does the presence or absence of classical risk factors affect the lifetime estimates of cardiovascular disease and death from any cause remains unclear. In this trial, they harmonized individual level data from 2,078,948 participants across 133 cohorts, 39 countries, and 6 continents. The lifetime risk of cardiovascular disease and death from any cause was estimated up to 90 years of age, according to the presence or absence of arterial hypertension, hyperlipidemia, underweight and overweight or obesity, diabetes, and smoking at 50 years of age. The lifetime risk of CV disease was about 24% among women and 38% among men, for whom all 5 risk factors were present. The additional life years free of cardiovascular disease was 13.3 for women and 10.6 for men. The estimated number of additional life years free of death was 14.5 for women and 11.8 for men. As compared with no changes in the presence of all risk factors, modification of hypertension at an age of between 55 to 60 was associated with the most additional life years free of CV disease, and modification of smoking at an age of 55 to less than 60 was associated with the most additional life years free of death. So to conclude, the absence of 5 classical risk factors at 50 years of age was associated with more than a decade greater life expectancy than the presence of all 5 risk factors in both sexes. Persons who modified hypertension and smoking in midlife had the most additional life years free of cardiovascular disease and death from any cause, respectively. The last trial, which came in today at the ACC, which was interesting, was the SMART Choice 3 trial. Clopidogrel versus aspirin monotherapy in patients with high ischemic risk after PCI. Now, the question is that the optimal strategy for long-term antiplatelet maintenance for patients who have undergone a PCI remains uncertain. This study aimed to compare the efficacy and the safety of clopidogrel versus aspirin monotherapy in patients who completed a standard duration of dual antiplatelet therapy following PCI with drug-eluting stents. This was multi-center, randomized, open-label trial in patients aged 19 years or older who had high risk of recurrent ischemic events and who had completed a standard duration of DAPT after PCI. They were randomly assigned 1:1 to receive either clopidogrel at a dose of 75 mg once a day or aspirin 100 mg once a day. And this was done at 26 sites in South Korea. The primary endpoint was the cumulative incidence of a composite of death from any cause, myocardial infarction, or stroke, assessed in the intention to treat population. Adverse events were captured as part of the secondary endpoints. Now, this happened between August 2020 and July 2023. 5,542 patients were assessed for eligibility and 5,506 patients were randomly assigned. Median follow-up period was 2.3 years. The primary endpoint occurred in 92 patients in the clopidogrel group and 128 patients in the aspirin group. Death from any cause occurred in 50 patients in the clopidogrel group and 70 in the aspirin group. There was no difference in the risk of bleeding between the clopidogrel and the aspirin groups at 3 years, and clopidogrel was not associated with a higher incidence of any adverse event as compared with aspirin. So the interpretation from this trial was that among patients who are at high risk of recurrent ischemic events and who have completed the standard duration of DABD following a PCI, clopidogrel monotherapy compared with aspirin monotherapy significantly reduced the cumulative incidence of a composite of death from any cause, MI, and stroke without an apparent increase in the risk of bleeding. So that's all from the ACC today. Thank you so much.